All right then, you are halfway through. There are some conditioning theories. And basically the idea here is that stuttering is reinforced. That is to say, a strict behavioral interpretation of this. But unfortunately, this doesn't really define the origin. It simply describes how stuttering continues. Does little to say what happened in the first place. There have been some interesting neuroimaging results now that we have some dynamic neuroimaging. That is to say, we can look at the brain while somebody's engaged in speaking. And that's what people are currently studying. Other people have studied the language of stutterers and noticed some interesting, subtle, but significant differences in the language of stutterers. It is important to consider the cultural or ethnic background of people who stutter. It is appropriate, for example, to use the name that that culture uses for stuttering and for people who do stutter. And some of these are fairly obvious to you all, but avoid overgeneralizing by using terms such as minority, culturally deprived, or culturally disadvantaged. Those simply are not useful or constructive terms. Okay. Now, there is such a thing as normal disfluency, and this is noticed usually at ages 2 or 3. And the normal disfluency, which my youngest daughter actually engaged in for some time, I noticed, is characterized by some revisions and pauses. She would talk like that. And that's typical of people who have young kids who have normal disfluency. Usually lasts weeks or months, sometimes a little bit longer, but not usually. And these normal disfluencies can rarely persist through adulthood, very rarely. When it does, we simply call it stuttering. So there are some phases of stuttering to deal with next. First is the episodic. Phase 1 is episodic stuttering, and that's where the child is usually stuttering during an episode of being upset, has a lot to say, maybe under a lot of pressure to say it, and the repetitions usually are of words or syllables. Usually that happens at the beginning of an utterance, and the child doesn't usually pay much attention or show any concern towards it. In phase 2, considered chronic stuttering, here already the child is thinking of him or herself as someone who stutters. Often the stuttering episodes are on major parts of speech, so this isn't going to happen on the or an or his or her. It's going to happen on the content words. And often this increases when the child is excited or is trying to speak more quickly. And again, the child doesn't seem to show as much concern just yet. Often this is during the elementary school ages. In phase 3, this is called specific stuttering, and that's where the stuttering might vary under specific conditions, like if there are certain sounds or words that are more difficult than others, if the child may avoid saying particular words or substitute words to take their place. You recall from the Stuttering Foundation clip the child who was concerned about the S sound, that was a particularly troublesome sound for him. There still is little avoidance of talking situations, and not outward evidence of embarrassment. In phase 4, called anticipatory stuttering, the person is fearful and anticipates stuttering, expects that stuttering is going to occur. They might make frequent word substitutions. They might avoid speech situations. This often occurs during late adolescence and adulthood. There is a powerful need to avoid stuttering on the part of people who stutter. And this makes the person feel, of course, different, unaccepted, alone. Here, during the anticipatory stage, there is the feeling that the person is different, and that's where the secondary behaviors often develop. The eye blinking, head nodding, shoulder shaking, and so on. So here's a flow chart that has the core stuttering behaviors on the left side and the secondary behaviors on the right side. And I'll let you peruse that slide. I'm not going to talk a lot about assessment or therapy. You will get plenty of that if you pursue this field. I will talk about it briefly, just since it's a little bit interesting here to perhaps the rest of you. During assessment, we need to distinguish between what is normal disfluency. Remember, I talked about how that happens in young childhood, and stuttering, which can persist. Well, all stutterers, of course, went through that young childhood, and so we need to help determine whether this is somebody who is just going through a period of normal disfluency or whether this person is highly at risk for developing stuttering. This assessment includes an assessment of the environment, that is to say, the person's home, family, to determine what pressures exist in that family. Here are some warning signs for stuttering. And I'll let you go through those, but one of these that may not be intuitively obvious is the difficulty in starting or sustaining airflow or voicing for speech. The fear, avoidance, and so on, some of these are not outwardly noticeable. Our assessment includes a description of the behavior itself, that is to say, a very fine, detailed description of the stuttering behaviors. In other words, for example, do they occur just on words or on syllables or on individual sounds and so on? We need to assess the impact of that on the person's life and make a determination about a treatment plan and the prognosis for improvement. There are two main types of stuttering therapy. There's something called fluency shaping, and then there is stuttering modification therapy. With fluency shaping, the person is learning to speak more fluently, of course, without stuttering, and there is the establishment of a basic form of fluency during therapy. You reinforce it and you gradually modify it so that this approximates normal sounding speech. That's fluency shaping in a nutshell. Stuttering modification, the person's encouraged to stutter in a more easy, controlled manner. Okay, and there is a confrontation of the fears and an extinguishment of avoidances. So the fluency shaping is designed to get rid of the stuttering, whereas the stuttering modification is designed to make the stuttering sound a little more normal. Most therapists will do somewhat of an integration of the two approaches where there is a modification of the stuttering and an eventual attempt to get rid of it altogether. There are some electronic devices available. They work. However, what they don't do is fix the stuttering in the absence of those electronic devices. They're small, unobtrusive. They look like hearing aids. They're about the same size. They introduce masking noise in the stutterer's ears, and or they introduce delayed auditory feedback. parent-directed intervention is something very popular in Australia, becoming more popular here. Essentially, the therapist trains the parents to become the therapist, and this is called the LITCOM program. And the focus here is eliminating the stuttering entirely, so this would be considered a fluency shaping therapy. Okay, that is the end of this unit. Thank you very much.